Hello everyone, I am Divyashini Anbalagan from Group 3 and today I'm going to be talking about airway management and how to maintain an airway and breathing in a patient in cases of trauma. So the causes of airway mismanagement. So airway mismanagement in trauma victims may attribute to many of the causes, which is failure to recognize the inadequate airway in the trauma victim, failure to establish a clear airway with or without an airway device, failure to recognize that the airway device that has been employed is incorrectly placed, displacement of a previously established airway, and failure to recognize the need for ventilation. Lastly is aspiration of gastric contents. An inadequate airway would lead to asphyxia, which that may progress to cerebral hypoxia, which is brain damage, and finally death. So what are the locations in which airway mismanagement can occur in the trauma of the patients? And they are unfavorable conditions like darkness, inadequate space, limited access to the patient's airway, poor patient positioning who may be lying on the road, cramped, smashed cars and trains, and other unusual location. Also, unknown assisting personnel with different levels of airway training can also cause to difficulties. Causes of airway difficulties leading to airway mismanagement and the trauma include oropharyngeal or pulmonary hemorrhage, an immobilized cervical spine such as in cervical collar, a possible full stomach on the assistant applying faulty cricoid pressure, and uncertain volume status putting a dilemma on the use of pharmacological adjuncts, hypoxemia putting stress on the operator, and uncooperative or combative patient. So the prediction of inadequate airway in patient of trauma. So potential trauma patients who can have inadequacy of airway include patients with altered consciousness secondary to head injury, drugs or alcohol, direct trauma to airway like the facial-maxillary, neck, larynx and throat, severely wounded patients having profound bleeding or are comatose, and respiratory failure secondary to blast or inhalational injury or exposure to chemical agents. So there are some simple steps to help identify the obstructed airway of some of these potential patients, and they include three, which is look, listen and feel. So we have to look for obtundation, agitation, cyanosis, retraction or use of accessory muscles of respiration, and the asymmetrical rise and fall of the chest. We have to listen. Listen to patient attempting to talk but failing to do so. Abnormal breath sounds associated with snoring, gurgling, stridor, and crackles. Asymmetrical breath sounds over both hemithoraces and tachypnea also suggest an inadequate airway. We also have to feel. Feel for a deviated trachea and a subcutaneous emphysema. Patients with any or combination of the above should be presumed to have an inadequate obstructed airway needing appropriate management. All patients of trauma should be suspected to have an altered or compromised airway till ruled out. So the simple way of identifying an inadequate airway, we have to take the opportunity to take a sample history of the patient's condition. The sample S stands for signs and symptoms, A stands for allergies, M stands for medication, P stands for past medical history, L stands for last meals, and E stands for event prior to injury. So these are the steps to look into patient if they have inadequate airway. And once we have identified that the patient has inadequate airway, we can start to adopt a simple airway strategy, a definitive airway strategy, an ETI or a surgical airway, and a semi-definitive airway strategy for making the airway patient as per existing the situation. Simple airway strategies includes the head tilt and chin tilt, where we avoid in patients with cervical trauma, and where jaw thrust or the use of basic adjuncts such as oropharyngeal airway will be used in unresponsive patients. The definitive airway strategy is when it includes the presence of apnea and need for airway protection from aspiration. There is also risk for obstruction such as neck hematoma, laryngeal tracheal injury. And lastly is the semi-definitive airway strategy, which is clearly defined in the management of trauma patients, where it includes a laryngeal mask airway, a laryngeal tube, and that is all. So that is all from me today. Thank you so much. Hope this information can help us save a life someday.